Good evening, everyone. My name is Russ Tupling, and I'm the chair of the Department of Kinesiology and Health Sciences, Faculty of Health, University of Waterloo. Welcome, and thank you all for joining us this evening for the Holman Lecture by Dr. Paul O, entitled Exercise as Healthcare, Past, Present, and Future. Let's begin by acknowledging the land that we are gathered on today for this lecture. We acknowledge the University of Waterloo is situated on the Haldimand Tract, land granted in a legally binding treaty to the Haudenosaunee of the Six Nations of the Grand River. The land inside and surrounding the Haldimand Tract is the traditional territory of the Attawandaron, the Anishinaabeg, and the Haudenosaunee. On June 20th, Dr. Lily Liu, Dean of Health, made a full commitment in ceremony that the Faculty of Health will create an environment that invites and respects Indigenous ways of knowing. At a commitment ceremony later that year, September 22nd, Elder Maingan Henry, who's Indigenous Knowledge Keeper in the Faculty of Health, on behalf of the Indigenous peoples of the University of Waterloo, asked President Vivek Goel and all of us who were in attendance for a full commitment to reconciliation, indigenization, and decolonization at the University of Waterloo. The President acknowledged the university's full commitment and asked all of us to participate in this institutional commitment to foster a better understanding of Indigenous history, to develop an awareness of the damaging intergenerational effects of colonization and the residential school system, and to take responsibility for vital components of the reconciliation process. Today's Holman Lecture is in celebration of 20 years of UW-WellFit and a look to the future for the Center for Community, Clinical, and Applied Research Excellence, or CARE for short, in the Department of Kinesiology and Health Sciences. UW-WellFit is a clinical exercise program that aims to improve the well-being of people with cancer. And being one of the first in Canada was the foundation for other community programs, including those after stroke and for people living with dementia. Over the past 20 years, I have witnessed and supported the development and growth of UW-WellFit. It has flourished from its humble beginnings at the Manulife Wellness Center, which is attached to this building, to more recent years at the Toby Jenkins Applied Health Research Building, located on the North Campus in the David Johnston Research and Technology Park. UW-WellFit not only serves a clear need in our community, but importantly, it also contributes broadly to major strategic priorities of the Faculty of Health and the university, including meaningful education through experiential learning for over 300 students every year, opportunity for impactful research related to health, function, and well-being in relation to movement and exercise, and of course, community engagement and partnerships. I look forward to the next 20 years of important research, community, and educational partnerships delivered through CARE that will help sustain improved health and well-being for our community, locally and abroad. Now, it is my pleasure to introduce the Dean of the Faculty of Health, Dr. Lily Liu, to say a few words.
Thank you so much, Ross, for that introduction. I want to thank each of you for taking time from your personal lives to join us for this very important talk. To Laura, Russ, and the whole team who have put a lot of effort into organizing this, and of course, a huge welcome to our speaker today, Paul O. I want to take a few minutes to talk about the funding that has made this event possible, this series of events. And these are what we call the Holman series. This series explores the Faculty of Health's commitment to excellence by bringing timely and topical learning opportunities to our university and the broader community, of which many of you are. This is made possible by generous legacy left to the University of Waterloo by Lyle Holman. Now, Lyle was committed to making lasting difference in his home community of the Waterloo region. And this difference is realized by supporting local organizations to foster relationships that lead to resilient, connected, dynamic, and creative communities. The funding that the University of Waterloo has received from Lyle and his wife, Wendy, has empowered our faculty, the Faculty of Health, to make strides towards our vision of protecting and promoting health and well-being for individuals and communities, both locally and across the globe. We are so proud to share a vision with the Hallman Foundation to optimize health prevention, and we are very pleased to acknowledge and show our gratitude to the Hallman family for their leadership and support. Thank you.
Hi, everyone, and welcome tonight to our Hallman Lecture. I'm so glad you took time out of your evening to be here to hear our speaker, Paul O, as well as an amazing panel before us. Thank you to Russ and Lily for your opening words. I know Paul's lecture and the following panel will be an engaging way to spend the evening, and so a good investment of your time, especially for many of you who have a passion for exercise and its role in improving the health and well-being of our community. As Russ has highlighted, this is the final celebration of the 20th anniversary of WellFit. I'd like to highlight the contributions of Carol Russell, one of our panelists, who has been the director of programs for all that time and has been our estimable leader in creating not only an effective exercise program, but a family amongst the participants and amongst the staff, many of whom are here today. This includes Anita and Beth, who are both discussants this evening. I know that the foundation that all of you have created within the WellFit will be a strong springboard for the next 20 years. This started with our expansion into the Toby Jenkins building, and then our expansion to wellness programs, not only for people with cancer, but also for people after stroke and people living with cognitive impairment. And I hope our impact will reach not only those in our programs, but also the community, as well as beyond and across the country. Our innovative faculty-led research at the Center for Clinical, Community, and Applied Research Excellence will continue to drive innovations in care, prevention, and basic understanding of movement, exercise, and chronic conditions. Importantly, the partners developed through our programs and activities at CARE, the region of Waterloo, and across Canada and the world will facilitate the spread and adoption of programs and technologies arising from our researchers. I cannot think of a better person to celebrate the last 20 years and start us off right for the next 20. Dr. Paul O is a cardiologist, medical director, and Good Life Fitness Chair of the Cardiovascular Disease Prevention and Rehabilitation Program at the University Health Network at the Toronto Rehab Institute. He is an associate professor of medicine at the University of Toronto and a senior scientist at KITE, which is the research center of the University Health Network. Importantly, he is a passionate promoter of exercise, both in research and in the practice of healthcare. Over his 20 years as the medical director of the Cardiovascular Prevention and Rehabilitation Program, he has catalyzed important, innovative healthcare research. Leveraging his expertise and the people in his facility, he oversees the programs that benefit patients and community members well beyond the cardiac core of his mandate. His leadership has led to fitness programs supporting those with stroke, those with cancer, those with cognitive impairment, and beyond. He has been a leader in countless organizations promoting physical activity beyond his institution, the Canadian Association for Cardiac Rehabilitation, Participation, and the Cardiac Care Network of Ontario. It is my pleasure to introduce our Hallman lecturer, Dr. Paul O.
Laura, thank you very much for that really, really kind introduction. Russ, Lily, it's a pleasure to be with you. Colleagues, I've been here for the day, got in before the storm. I'm committed to staying for the night as well. If you'd like to have later conversations, it's a pleasure to be with you. It's a privilege to be on this land and to be able to share and gather here today. Some of you I saw through the day, about 12 hours ago I saw you, and we're still in conversation. This lecture it's a real honor to be able to deliver to you. This is a group of committed individuals. I know every one of you here in person and online are committed to health. And I could think of no better institution than Waterloo to be championing these sort of activities and to celebrate the excellence that you have provided to the community and to the academic world and clinical world in cancer, prevention programs, in cardiac care, in healthcare overall. So thank you very much for this opportunity. This is going to be a 30-minute discussion, plus or minus, on a topic that's near and dear to all of us, and particularly in the work that I do on a daily basis around the importance of physical activity and fitness and movement and just not sitting around. Whatever words that one might want to use to say that moving more is a good idea. And through that kind of mechanism, we can prevent and we can better manage the conditions that we have. Here are a few disclosures just to say who I am and that you know who I am, that I have served on some advisory boards. I do hold some research funding from national organizations, and I have a research chair actually supported through Good Life Fitness through our hospital foundation. And I hold some research activity with Apple. Say there's a broad range of activities. So there's a number of players in the community that are interested in this kind of activity. And as Laura kindly mentioned, that I do have the opportunities to sit at some tables where these important issues are discussed. And if in a small way we can help nudge the needle so that we can create a healthier environment overall, then that's time well spent. Here are some topics that we'll cover off in the next little while. And for those of you who we were together with this morning, I apologize. We may go over a bit of the same territory, but I think there are some new faces here this evening. So we'll hit the highlights, so to speak. We'll hit the high points of why should we be interested in this topic area? What's the deal in healthcare? And why might it actually be sick care as we work on burdens of chronic disease? Even those words are terrible, right? The burden, the nuisance of chronic disease. Well, we're not that pejorative when we don't mean to be, but let's talk about why this is a burning platform for us and why a solution might be something that's in our power, in our hands, in our feet, in the chairs that we might be sitting in, the power to actually transform our own health and the people around us. If we think about exercise then as a medicine, a drug, a pharmacological therapy, how much might we need? Is there a dose in a duration that might actually be beneficial? And if one is living with a chronic condition, and indeed many of us are, what might we still be able to do to improve that situation? Ultimately, this is about making choices, and making choices on a daily basis, hourly basis, minute by minute. The things that we choose to do can actually impact the way that we feel and the way that we'll be over the future. And then ultimately, I think one of the rationales for coming here together around the Hallman series and for universities to host programs like this for communities is that we can figure out ways to work together. And indeed, over the last number of hours today, we've engaged in a number of those conversations, have had those wheels turning on both sides of how can we create some solutions so that overall we can develop a healthier community. That's exciting. Okay, so now some of the bummer stuff, right? Okay, so let's set the stage that there are these things that are labeled as chronic diseases, kind of on a global basis, and it's true in North America and in Canada as well, that there are conditions that develop over time and that persist with us. That's the chronicity of this, that there are conditions that come on and they hang around. There are common things, like in my world, I see people with heart disease. In the middle to upper panel, that's a representation of people that might be living with a form of diabetes or some other metabolic or endocrine disorder. On the right-hand side, people that might develop a cancer and hopefully recover from it through wonderful therapies and the exciting interventions that we're going to talk about in the panel. Left lower are people that might be living with lung diseases. Lower middle, mental health issues, depression, anxiety that are so common, especially amplified during this time of COVID, and inflammatory conditions like arthritis. So if this was a game of bingo, a sad game of bingo, you might tick off the box and say, yeah, I got that one, got 5 in a row. Do I get a prize? So these are common. Indeed, how common are they? If we look across a survey of Canadians, indeed, it is very common to have one of these conditions. And as we age and get up into my snack bracket, it's not uncommon to have 2 or more. And indeed, if we think about like Canadian adults on average, that about 80% of people will live with at least one chronic disease. So this is more the norm. So is it normal to be diseased? No, I don't think we should think of it that way. It's just that we accumulate conditions. We accumulate some wear and tear in our lives. And that is the way that we live. But the things that we need to do then is how can we live better with the chronic conditions that we have? It's important as well, not only might we live with a condition, the real bummer stuff is that some of these chronic conditions unfortunately may progress, may amplify, may get complicated. And if we think about the reasons that people actually pass on, often it relates to these chronic conditions. So this is high stakes, right? So 80% of all the deaths that occur in Ontario relate to these chronic conditions, notwithstanding the devastating effects of the ongoing infectious pandemics that are going around that we've been talking about in great detail. In the background, this was still going on, and it's still going on today, and was perturbed in a great way by the impacts of things like infectious diseases. These don't go away. These don't take a pause while infections go on. So we need to keep our mind on this, the ongoing pandemic of chronic disease. So we've got great therapies, we've got surgeries, we've got interventions, we've got medications, but is there something else that we might offer up? Because while those things are great, I think often we're looking for something else that's in our own power that might make a difference. And it's exciting. Every now and again, it's typically in January of every year. Professor Middleton, will you be called by one of the media outlets to talk about January? Suddenly we discovered that exercise is a good thing every January. Why January? Because we're making resolutions. It's just around the corner. Get ready, everybody. You can recommit in the new year of 2023. And folks get excited and write headlines like this, that exercise is as good as medicine in treating diseases. So the media loves this kind of headline because I think it tells us that we're searching for something different, something exciting, something important, something that's in our own hands. And so these headlines are there. And when doctors prescribe exercise, it's revolutionary. Oh my God. You name it, exercise helps. And so the other point I want to put out is that just this last kind of headline here about the important role of us together and the University of Waterloo as a beacon, a leader in academic health sciences, and the allied health professionals who train, learn, excel through this institution are amazing and have such an important role to play in healthcare if we can just open up some more doors and opportunities. So that'll be the mission for all of us collectively. So the headlines get excited every January, but if we actually turn the clock back, so we're in an academic institution, so we need a little bit of history. So yeah, it's fun, right, to play the historical trivia game. So this one, from 400 BC, Hippocrates, the father of medicine, wrote lots of things that we're just trying to rediscover, right? And it's true kind of going through history. If we can give every individual the right amount of nourishment and exercise, not too little and not too much, we would have found the safest way to health. And we're just discovering that again and pretending, frankly, I've written many papers about this, frankly, my acknowledgement, my kind of confession that we do this. And we figure this out, we refine this, we figure out the dose, but we can go back and kind of rediscover what we've known for a long period of time. So I think all of you knew this already. You read ancient Greek scriptures, right? And so you say, yeah, we kind of knew this stuff, but it's still important. It's still novel. And I bet in January, you're going to find a headline somewhere that says, wow, we discovered that exercise is indeed a good idea. Medicine takes a long time to figure things out. So even though some really smart person wrote about it 2,000 years ago, 100 years ago, we were still doing this, that, we built medical institutions, we built large hospitals, and in those hospitals we had big rooms. And in the big rooms, you don't like empty rooms, right? So you put in a lot of beds. And if you put in a lot of beds, you have to put people into them. Form follows function, or function follows form. So if you build it, they will come. That's the other thing I wanted to say. So if you build a big hospital, lots of beds, you're going to put people into it. Indeed, that was committed as the medical model. We believed that this was the right thing to do. Because we have hospitals, we have beds, we're going to put people into it. And resting was the way that you help people get better. And the proof of it was, if you put somebody in bed for a long period of time and you allowed them to get up, oh, lo and behold, this was dangerous. The most dangerous place in the hospital a few decades ago was the bathroom. Because when people got up from bed after being lying there for a long period of time, they get up, they dislodge the clot that's lying in their leg, it travels up to the lung, and they die of a pulmonary embolism. But because we have this bias ahead of time, we would say, look, I was right. They should never have gotten up out of that bed. They died because they got out of the bed. Therefore, for the next decade, I'm going to keep you in that bed. Well, somebody very revolutionary then must challenge that model and say, maybe I won't let you out of the bed completely. I'll just put you into a chair, and you'll sit there for the next 10 years. And that's very brave. And then it takes another decade to say, hey, the chair went okay. Maybe I can let you walk for 3 minutes, right? So it's interesting how slowly things evolve. This article from 1965 in the premier cardiovascular journal called Circulation kind of spoke to this. And you can read this. It is our policy to place these patients at absolute bed rest. They forced them to watch television in 1965. What was available in 1965 on television? I have no idea. I'm not quite that old, but it's interesting. So not only do you put them in bed, you punish them. And it's interesting, when I trained as an intern in 1988, I did this, right, as well. I learned that my pen was one of the most powerful instruments that I could offer up. I do have a pen. Look, I still have a pen. I have a computer as well, but I have a pen. This was still my powerful tool. And in this, I controlled your destiny. Because I would write where to send you, usually to a hospital bed. I would write what kind of food you could eat. And I also had control over what activity. And I learned, because of articles like this, that if you came into hospital with heart failure, I should write bed rest on there. And then there was a team of people that would enforce that. Don't you dare get out of bed. Someone's going to tackle you and put you back into bed. That's how committed we were, right, to this. Interesting. It takes a while. It takes a few brave souls to say, I'm going to challenge the establishment. Maybe there's something not quite right with this kind of model. If I'm actually trying to change how people recover from heart conditions, then maybe we need to do something different. This guy was a cardiologist named Herman Hellerstein. 1950s, wrote in another big American medical journal called JAMA that we need to think about movement, rehabilitation, exercise at the time of diagnosis. That's when rehab starts. That's when health actually starts. Passivity, that is the act of lying in bed, needs to be terminated as soon as possible. And they recognize critically importantly that docs are no good at this, that we need the team, we need the allied team in particular to take a stand on this and actually help people get moving. In Canada, my predecessor at the Toronto Rehab Institute, Dr. Terry Kavanagh, was really the pioneer of cardiac rehabilitation, not only kind of locally in Toronto, but indeed around the world. And the WellFit program, celebrating 20 years. The cardiac programs in Toronto will be celebrating 55 years next year. We have this shared mission that no hospital beds anymore. Let's get people going. There is evidence for this, right, in the literature, that it's not something new. Actually, we've been accumulating evidence in the medical literature for a long period of time, looking at thousands and thousands and thousands of people around the world, where we can demonstrate a relationship like this. This somewhat complex graph, if you follow me here, the vertical axis talks about what is your risk of heart disease. And at the top is your highest risk of heart disease. And then as you go downward, your risk of heart disease goes down. Across the x-axis, the horizontal plane, are levels of activity. So as you move down and right on this graph, you are getting more active and you're lowering your risk of heart disease. At this level are people that get in about 15 minutes a day of moderate activity, meaning you go for a brisk walk, you get a little bit short of breath for about 15 minutes through the day. You can lower your risk of heart disease by about 7% by doing that. That's nothing to sneeze at. If you get to the Canadian targeted guideline, the arbitrary guideline of 150 minutes per week of moderate to vigorous physical activity, that's about 30 minutes a day, 5 days a week. You can have weekends off, thank you very much. That you can lower your risk of heart disease by about 14%. And then if you're really committed and want to get in like 60 minutes a day, 5 days per week, you can lower your heart disease risk by about 20% by doing so. So the heart disease risk relates to the amount of regular physical activity one gets. A lovely relationship. And this is, again, shown in hundreds of thousands of people all around the world. The arbitrary target that we talk about in Canada, and that's in every disease management guideline, says get 150 minutes per week or 30 minutes per day. That's good. Less is okay, more is okay. That's not a bad number to have in your mind. A bit more benefit will be derived from a bit more activity, all right? But the first step is going to be the most important step, because you can see that the sharpest part of the curve is on the left-hand side here. So that's where the most benefit is going to come from. How do you do this? In our program, in our cardiac programs, we work with people living with heart conditions, and I saw that there were wonderful assessment labs in the care center and in the Manulife Wellness Center, where people can actually do some detailed assessments to figure out where are we in terms of our heart behavior, our blood pressure, our electrocardiogram. Where's my fitness level? What's the right level for me to exercise at? And for some individuals, that kind of upfront assessment may be very helpful. For others, we can get going. And when we get going, think about that recipe, 150 minutes per week. How am I going to get that? Well, I'm going to do some aerobic kind of activity. That might be walking. It might be cycling. It might be in my chair as I wheel along. It might be rowing for other individuals. And then very, very importantly, and again, professors at Waterloo are champions of this, that we should get in some weight training, especially as we're getting older and we want to defend our muscles and our bones. So, so important. When we do that, and if we follow that as a program, it should be no surprise to you that we can derive some benefits. And when we did some analysis from our own population at our center, again, orientation here, the vertical axis, in this case, is people living or dying. It's good to be at the top. That means 100% of people are alive. Over time, and the horizontal axis in this case is about 5 years of time, people unfortunately are passing away over a period of time. The pink line, though, represents people who do a program as we've described. Get in those regular walks, get in that regular activity, lift the weights. The blue line is a comparison population living with heart disease that don't do the program. The difference is about 50% in terms of survival. Like, that's how much power is actually in your feet. You can change one's trajectory of living or dying. It's why the work that is done in this institution is so critically important for the health of the community. Why is this a problem for Canadians in general? Is because Canadians in general, unfortunately, maybe not the folks in this room, but Canadians in general, unfortunately, are fairly inactive. And if you measure this in different ways, like if you've got a step counter or you use your phone to actually count your steps per day, for most Canadians, it's only about 1 out of 3 that actually get to a sufficient level to derive a health benefit. If you measured this and actually measured the amount of minutes that one can walk where you're feeling a little bit short of breath, then the number of people that actually achieve that in Canada drops about 15%. And for those that might actually do this in a purposeful way, like on a daily basis in bouts of sufficient intensity, the number drops to about 5% of Canadians. So the majority don't get enough of this activity. So if we're gamblers, we would say there's still a lot of money that's on the table here that's within our grasp. And that's what we can do. If we look across other populations across the world, and again, this morning we had this conversation in our more detailed seminar, that we think about other risks for heart disease, but also this applies to risks for cancer, or risks for mental health issues, or risk for diabetes. That we think about smoking or high body mass or high blood pressure as kind of the common risk factors, and we identify them when we see our healthcare practitioners, and we act on them. Often we don't have the conversation about how physically active we are. But given that the majority of Canadians are physically inactive, it's a really, really important issue. It affects whether we live or die or develop heart disease. That this arguably is the most important thing that affects us on a daily basis. It's common, it has importance, it needs attention. And this is true for populations. Anybody above the age of 25, this is your number one issue, I would argue. If we do something about this, colleagues that are epidemiologists, they take populations and they crunch numbers and do estimations about what will happen. This is more of what's at stake for us. That if we can correct smoking, if we can correct alcohol intake, if we can eat better diets, if we can manage stress, all of these things are going to be important in terms of improving the longevity and quality of our lives. But maybe the most important thing that we can do, again, is actually get active. And if we get active on a regular basis, that might add 2 or 3 more quality years to our life. This is good. Along the way, you'll accumulate some wear and tear. You'll need new running shoes every 6 months or every 500 miles, whatever comes first. You will get more smelly. But you'll feel a whole lot better along the way. Because exercise and being active and moving improves so many things. Name something, it gets better with exercise. That's the participation adage, right? And that's true in a whole large series of literature. So whatever chronic condition one is living with, whatever chronic condition one wants to avoid, it will get better. An example, if my goal over the next year is to avoid diabetes, because I believe everyone can develop diabetes if you try hard enough. If you try hard enough, we're doing a good job right now, by the way, by being committed to our chairs. We're doing a very good job at this. And if you didn't move for the next few years, and we piled in the carbs and the sugars, then you will develop diabetes. So if I ask you the question, what's the best way of preventing this from getting worse? And the options would be you can either move or you can take some pills. The answer would be, we understand there's actually a pretty good relationship between our levels of fitness and our sugar metabolism handling. There are experts in this room, far more expert than I, that would say yes, that we can actually relate our levels of sugar control with our levels of fitness. And the more fit you are, the better able you are to handle sugar. There was actually a study, some guys did a study a number of years ago that compared this problem of people who were at risk for developing diabetes. Some people got a placebo, so they didn't really get any intervention. Some people actually got an active diabetes drug called metformin. It's the most common drug that we actually use to treat diabetes. And then the third group actually got a program of meeting with a dietitian and an exercise therapist and getting counseling on a regular basis to get active. The people that got the diabetes medication, they did lower their risk of developing diabetes. That's what's shown in the red bars here. In this case, the line that goes up and to the right is badness. The people that got the simple advice of you should do better, they got a lot of diabetes. In fact, about 10% per year developed diabetes. The ones that got the tablets, about 8% per year develop diabetes. But those who actually that got onto the program of eating well and moving more, about 5% of people develop diabetes. So you can cut your risk by half. Again, that's the power in one's hand. And if you're living with diabetes, similar kind of thing, that if you get active and you walk and you lift weights, that you can actually reduce your sugar levels by about 10%, which is as good as any medication that we can offer you, with far fewer side effects other than you feel a whole lot better. The programs at CARE are important for improving the lives of so many individuals affected with chronic conditions. One of them is stroke. And why do they run this kind of program? Because again, there's also a relationship between getting active and stroke risk. And as one gets more active, you can avoid stroke. Stroke is maybe the most devastating thing that we all are facing at some point, and maybe the thing that we want to avoid most of all. Once again, this is in our power. Cancer is the other area that you've gotten into so well for 20 years of tremendous leadership, and we've gotten into this area as well, as have a handful of other programs. And it's encouraging to see that finally big organizations like the American Heart Association and the American Cancer Society have actually endorsed that exercise is indeed a good thing. It took a long time. You know, medical folks learn very slowly. We built big hospitals, we put them in there. We committed to changes probably every 10 years. So maybe this is the decade where we'll actually put this into action. So there's this statement that says, rehabilitation will improve cardiovascular outcomes in people living with cancer. Okay. We couldn't go away without talking about COVID, right? So what's the deal with COVID? Because we talked about all these chronic conditions. They're not going to affect me long term. But what about COVID? So in this last year, obviously, there's lots of work done in COVID. And here's a couple of papers that were in the headlines from last year. So one analysis of 1.8 million adults, another of 65,000 adults, different places in the world, but relating the risk of COVID with physical activity patterns. To say, hey, maybe make a commitment today might make a difference. I'm not concerned about diabetes 5 years from now, but I am living with COVID in my environment. And what's interesting, 2 big studies, completely different geographic areas, interesting, consistent findings that people who are active on a regular basis have a lower risk of infection, have a lower risk of bad infection like getting into hospital, lower risk of getting into the ICU, and ultimately a lower risk of dying. And it's remarkable the consistency here. You can cut your risks almost by half by being active. No, so do you need another reason? No. But we said that you've been committed. You've been awfully committed to being here this evening, and I thank you for it. Usually when we do a session like this, we ask you to sign the waiver on the way in. Did you sign the waiver? That said, I agree to sit and listen to this person ramble on for a while, and I agreed to put my risk of dying up over the next 30 minutes, because sitting is a bad thing, right? And again, this isn't a new thing that we learned. There was this interesting study done in the 1950s, the London transport worker, the London bus study, right? So can I tell you this story before I leave you? So double-decker buses in London, phenomenal, beautiful, like a great kind of symbol of Londonism, right? 2 people work on the bus. The guy who drives the bus is called the driver. Thank you very much. There's also one other guy, or bloke, I speak English, bloke, who collects tickets. He was called the conductor. And I'm not trying to be sexist here, but in 1950, it was only guys that did this, right? So you can control for sex in this analysis. It's great. There's a guy on the bottom, a guy on the top. They come from the same community. They eat the same food. They drink in the same pub. They smoke the same things. They may be married to sisters, I don't know. So there's lots of controls of social things here. The only difference for the driver and conductor is what they do through the course of the day. The driver drives the bus, sits all day long, driving the bus. The conductor has to stamp tickets, runs up and down the stairs because it's a double-decker, does 600 stairs per day. You know where this story is going, right? That if you look at their risk of developing a heart attack, a coronary occlusion, as it's called in 1950, or death within 3 days of that occlusion, you can see there's this striking difference. The driver has 4 times the risk of developing a heart attack, 3 times the risk of dying compared to his colleague who runs up and down the stairs all day. So the only difference is whether you sit or not. Sitting is hazardous. Sitting increases your risk of dying, of developing heart disease, developing diabetes. Importantly, even if you're active, prolonged sitting doubles your risk of cardiovascular death, even regular exercises. So you'll remedy this, right? And it's purposefully built into this very thoughtful evening. You'll sit for a little bit, but you will get up and you'll mingle and have some nosh, and it'll be good. All right? So we need to break up our activity that way. I would argue that the most dangerous place in the house is this. We thought it was the bathroom. It was in the 1950s, but this is the most dangerous place now. And it intrigues me that if you are going to be so inspired this evening that you'll go home and put in a VCR tape. Anybody do that? DVD, anybody? No, pull up something on your streaming service. Something active. I'm going to do chair yoga tonight. And the first thing that will pop up on the screen is a warning to say, caution. What you're about to do can be very, very dangerous for you, right? Please consult with your healthcare provider before doing this chair yoga program, because we don't want to be responsible for what happens to you. But yet, on your way home, you could go to the local furniture store. You could buy this couch. No one's going to warn you that this could be dangerous. So I think we should put warning labels on things like this and consult with people that this may actually kill you. The chair yoga's fine. It's good. It takes time. People recognize in the cardiac world, 1930, 1940, 1950, 1960, we're finally getting there where they said, hey, you should look at fitness as a new vital sign. So we're getting there. How do we do this as a community, setting up for the panel? So we do things in healthcare. We do things to you as members of the public instead of with you. There are these wonderful places, fitness facilities all over the place, and we'd love to access them and make them part of our community where everybody lives in the bottom. But sometimes it feels like we just got barriers and walls all over the place. Why can't we work together? This is actually a theme that I was hearing today. I didn't know it before I got here, but it seems to be true that folks feel like we just can't work together as easily as we need to ultimately help people get more active, get the care that they need, whatever might be the cause of the day. So we would love to build the system where we break down those barriers and create those opportunities together. And I think that's what we're going to cover off in the panel. So a couple of summary slides, and I thank you for your attention. Being active, good. I think you all knew this. Not too much, not too little. Small steps go a long way. The first step is the most important. Standing up helps as well. Doing the weights in addition to the aerobic training is really, really good. Physical activity, exercise, keys to disease management. If we're living with the condition, we can modify things for sure, but it's always better to be active than inactive. And sometimes what my colleagues will say, I don't want that person to be active because it's too dangerous. What we accept tacitly, as we did in the room, is we'll accept that we can sit. Will raise our risk of dying. But we just accept that. We can do something about that. We can break down some walls. We need better focus on prevention. Again, it's interesting. These conversations came up spontaneously today, but we just kind of thought that maybe this is the things we might get into. Moving medical exercise rehab programs to fitness settings and into the community might be one way of doing this, and it's encouraging to see programs like this kind of set up and celebrate and have such success over a long period of time. And then finally, for the colleagues in the room that come from this school, that exercise professionals are indeed core health team members. They need to be recognized and celebrated that way, and we're very pleased and motivated that the schools like Waterloo will develop this next generation of professionals, because there's such an important role. There's so much work to be done. We can do this together. Thank you very much.
Thank you so much, Paul, for starting us off on the right foot with a good spark to start all our thinking on how we can solve this problem together. I know for those of us in the department, we have been thinking and problem solving all day of how we're going to solve, well, all the world's problems, but especially these questions around exercise and physical activity. While I'm introducing you, I might next invite the panel to come up to join us in just the conversation that you alluded to, Paul. So joining Paul tonight, we have our breadth of expertise to share with you. We have perspectives of Paul as a clinician, as well as others. We have exercise professionals, and we have people who offer lived experience of participating in our fitness programs. People who have participated and thrived. This starts with Anita O'Brien and Beth Brown, sitting on the end, who are amongst the very earliest participants in our WellFit program. And in fact, Beth is the very first participant in WellFit and continue their participation to this day. I'm not going to go in order, but we also have Donna Van Allen, who is the director of the Grand River Regional Cancer Center and Waterloo Wellington Regional Cancer Program, as well as Lori Temple, who is the oncology coordinator from the same program, but also has the neat perspective of also being the daughter of a longtime WellFit attendee. This center, both through these two women, as well as as a whole, has been a strong supporter of WellFit for many years. As Paul alluded to, it's those connections in the community that allow us to thrive. We have Carol Russell, who I spoke about earlier, who is the founder and longtime director of the WellFit program, as well as the director of programs at CARE. In addition to these roles, she's also a clinical exercise physiologist and instructor in the University of Waterloo Department of Kinesiology and Health Sciences. Finally, we have Matt Mendez, who is here as a registered kinesiologist and the community program's clinical coordinator at the Guelph Family Health Teams. He has great insights for the role of kinesiologists within family health teams. He also sits on the board of directors for the Ontario Kinesiology Association. I will start with some prepared questions for our moderated panel. But in the meantime, you can think of your own questions for when I open up the microphones in about 20 minutes or so. For those of you online, you're welcome to type in your questions to the Q&A at any point along the way. So now let's start. I'm going to start with the most important voices on this panel, with Beth and Anita. As I said, Beth, you were the very first WellFit participant, and Anita, you weren't far behind. To you, I ask, what has been the greatest impact of WellFit to your health and well-being? Go ahead, Beth.
Okay, thanks. Thanks, Laura. Before I answer your question, I thought I would tell you how I got involved with WellFit, with the program. And since I was the first participant more than 20 years ago, I thought you might be interested in what the program looked like back then and how we have grown. My journey with exercise as medicine began shortly after I was diagnosed with breast cancer late in 2001. At my first appointment at the Cancer Center, among the overwhelming pile of paper I received was one describing a new exercise program for cancer patients run by Carol Russell at the University of Waterloo. Steve, my husband, said, well, he thought it looked interesting. And with a nudge from him, I called Carol. Unbelievably to me, her recommendation was that I start the classes while I was receiving chemo. Oh boy. I started the classes. At first, it was just Carol and me. Sometimes my daughter Susan joined us as a volunteer. I dragged myself to those classes twice a week, so tired, so sore, and sometimes nauseated. Each day, those negative side effects associated with cancer treatment disappeared for a while. I began to feel stronger, and to my surprise, I began to look forward to our time in the gym. Our group started to grow. We were joined by 5 others. Lori Kramer came on board to work with Carol to put us through our paces. We didn't even have a name, but we were off. I have continued in the WellFit grad program called Stay Fit until this day. Now, there are 150 participants weekly in the Start Fit, Stay Fit programs. Carol and Lori, who are exercise physiologists and registered kinesiologists, have been joined by 4 others with the same credentials. They are our heroes. We have outgrown 2 gyms. 2,650 participants have gone through this program since its inception, just over 20 years ago. Laura has asked me to comment on the greatest impact WellFit has had to my health and well-being. For me, it's difficult to narrow it down to just one thing. The most obvious impact, I think, is the physical one. The skilled exercise physiologist, registered kinesiologists who oversee our classes, assess each participant and develop an individualized exercise prescription based on our abilities. They closely supervise the classes that run twice a week for 1 hour each time. The exercises include cardiovascular, balance, flexibility, and muscle strengthening exercises. The prescription is reviewed and changed every 8 weeks. We work hard. I've become very strong, I think. And while I can no longer catch my grandkids, I can give them a run for their money arm wrestling or doing a plank. We work on achieving and maintaining good physical fitness. I believe that good physical fitness can lead to good mental health. It feels so good to be able to walk long distances and accomplish my daily activities as well as possible with renewed energy and enjoyment. The mental and social impacts are added positive experiences I wasn't expecting from WellFit. Our group is so supportive. We all cope with cancer in our own way, but we all have this shared experience. We celebrate our successes and support each other when bad things happen. Many of us have made lasting friendships. Our gym is a happy place. It is safe, private. There is no judgment there. The atmosphere is always positive. WellFit is so much more than treadmills, weights, and machines. All these impacts contribute to my overall health, well-being, and quality of life. I am grateful for the vision of Carol Russell and Mike Sherritt, who created our program. Grateful for the skilled leaders who design and run our programs and who have become friends. Grateful for the lasting friendships I have made. And grateful for the many physical, mental, and social benefits I receive that I know I could not receive elsewhere. I am so happy I dragged myself to those first classes 20 years ago. Thank you, Carol. And thank you, UW WellFit.
Well, my story is similar, but not quite the same. 17 years ago, I was given the diagnosis cancer. And at that time, the oncologist sat down with me and my husband and said, well, we have to develop a 15-year plan for you, Anita. We're looking at medication, we're looking at treatment, we're looking at possible other cancers or surgery. 15 years. And luckily for me, she didn't hand me a paper saying, try these exercises. She handed me a prescription and said, I want you to go to WellFit. I am not a group joining person. I do not go to other things like that. However, this was a doctor handing me a prescription. So, and again, my husband, get going. So I get to WellFit, and I was totally surprised. This was a group setting, but I was treated as an individual with individual needs, certainly different individual physical issues, and I met somebody who prescribed for me a program that I could accomplish, who watched what I was doing, who explained things to me and not physical, your abs or this or that, which who knew anything about that, but Anita, here's how you can do this, here's how you can do that, here's how you can prevent getting lymphedema. Who knew what that was? All of those things. So it was a total surprise for me, and it was guidance on not just how to deal with the side effects for medications or surgery, but how to actually feel better about yourself and have better health. Nice surprise. But WellFit to me is more than that. Through a lot of the informal things we do, again, I don't join groups, through informal interactions, when you're putting on your shoes or you're cleaning a piece of equipment or moving past somebody, people share their experiences. People ask about, did you ever have this? Or do you know about that? You motivate each other. Sometimes you're very, very tired and you don't want to go, but you do go because Beth's going to be there and I'm not going to disappoint her that I'm not there. Or I want to see how so-and-so did after their surgery. That motivation is there. That gets you going. We've even found some new clients that have come that are fearful of the unknown. We've been through some of that, so we can share. That's the important part of it to me. And you know, there are volunteer students there, and I find the interaction with those students makes me feel I'm giving back. I'm giving them some experience. I'm giving them some education that hopefully will help them go on to find better places for the rest of us. Being the fittest you can be can help you face the next challenge in a positive frame of mind and body. And it's helped me through 3 surgeries, the last of which was in January. And they provided, during COVID, programs that we could do in our own homes with people watching us during Zoom and saying, no, Anita, you're not doing that one quite right. So it was a support that was happening, kept me healthy, got me through last surgery. So thank you again for that. But this program isn't just a one off-the-shelf thing that you could go into a store and pick it up and use it. People are seen as individuals, and I must say the professionalism of the staff is just amazing. They accommodate and they support your other professionals you have to deal with. From the last surgery, I had to deal with a physiotherapist, and that work that I was to do was built into the WellFit program to make sure I actually did it. And finally, the last thing I'd like to say is the support of family has had a great impact on my health and my well-being. And I know Beth would say the same thing. We are fortunate to have very supportive families who motivated us to go, who made us go sometimes, and who encouraged us. But there are people at WellFit who may not have a supportive family near them. And from my observation of what I've seen over the last 17 years, the staff at WellFit, as well as the participants, can help fill the void if you don't have a supportive family with you. People at WellFit notice when someone's missing. They notice if someone is having a down day, or if someone is going to have a new medical procedure that they've never been to before. And no, you're not an expert, but you have an ear and you can listen and help them feel better and feel that there's somebody who really cares. And to me, that's a major part of WellFit as well. It continues to have an impact on my life and my health and my well-being. And again, I thank you.
Very powerful words. I think throughout everything you said, there is so much about the support of people, the people who got you there, the people in the program, the other people in the program who are supporting each other. It's very, just resonates, and that this is a connected community that are all important in achieving these goals. I think for both of you, though, you mentioned that the very first step in getting there was the referral from the oncology unit. And then your family who encouraged you to get there. But it led to a nice transition where I might direct it to Donna and Lori, because you both work, of course, in our oncology clinics. I'm going to you now. You probably have some of the reasons that echo here, but you have a complex array of management when you're thinking about looking after your patients. Why do you and your clinic refer to WellFit as a key component of the management of people undergoing cancer? What benefits really resonate with you?
So thanks, I'm Donna. Thank you for having me. I want to just take a step back, and I'm very humbled to be here. I see lots of familiar faces in both the room and on the panel. And I'll have to say that Dr. O, it was very humbling to sit there and listen to the progression of exercise, having worked cardiac, but most of my career of over 40 years in oncology, to recognize all those things that we did, we really did. And I, as a nurse, encouraged people to stay in bed. And I got heck for getting a patient out of bed on the cardiac floor. It's really true, and it's a bit horrifying at this point in my career. I'll have to say that I was a frontline nurse who looked after Beth. And it's humbling to be here and to hear what an impact we as professionals can have on one individual and encouraging them to go to some of these things. It may have been presented as a stack of papers, but somebody pointed it out as an important piece, or it would have sat in a stack. I would say that, you know, Anita, hearing that a physician took the time to write the prescription, because it's as important as any medication, is key. And I will say that I think as organizations, we can learn from our patients. So there's power in people, and there's power in working together. Is that not the most important lesson that we can learn? As the director of the whole Waterloo-Wellington Regional Program, that's the lesson. How can we as organizations work together? So when we ask our clinicians, our nurses, our therapists, our physicians, why say WellFit? I'll say, you know, maintaining that physical activity is a really important medicine. It's a really important treatment, as you can see from Dr. O. So that's one of the big reasons they do it. It actually improves cancer outcomes. I have never met a patient in my career that won't do anything to feel better or anything to improve their outcome. They'll do anything to feel better. That's why I love working with this population. You're so dedicated and you're so motivated. To be able to suggest something and put it in the patient's hands is powerful. It's very powerful. And they accept it. They want to self-manage as much as they can. So much control has been taken from them. They don't work, their finances are different, their family's sad, they want to live longer, they want to feel better. This is something they can do for themselves. And they can help themselves, and they're hungry to do that work. So that's another reason to do it. You know, the university started and had a white paper in 2011, and it was very powerful to see those statistics. All physicians respond to statistics and data. So having data and evidence is really a driving force for them to say, this is a good prescription for my patient. In 2017, to be sitting at the table with Carol Russell at Ontario Health Cancer Care Ontario, where we developed an exercise guideline where we're trying to get people to exercise, that it's as important as the oxygen we breathe and the smoking we don't do, the physical exercise is as or more important, was really powerful. And the University of Waterloo drove that. They were the experts in the room around the province. Like, when you think of all the big centers that are there, it's actually this university and this program that was really the guiding force. I can remember sitting at the table and everyone go, well, Carol, what does the university do? Everybody around the province was asking Carol. I can say that having organizational leadership to commit to working together is very powerful. Carol and I have known each other from the onset, and having the commitment to do this work for our patients is important. Having the clinician be as committed to write the prescription, to say, I am prescribing that you walk around the block 3 times every day this week, is very powerful. It's tangible. It's something tangible. It's not something airy-fairy. Patients want to decrease side effects, another reason where lots of clinicians prescribe exercise. And I will say patient commitment is probably the driving force. But if your leaders in your organizations, hospitals, cancer centers, universities aren't committed to working together, then we're not going to get anywhere. We can't build this in the hospital. I spent about 4 hours in budget meetings today. We really want to do what we have here, and I really want our patients to get there. And I think with the equity and diversity lens, it's really important that we say, we can't do it at the hospital, but we can commit to raising funds in our foundation to help our patients who don't have the funds to register to get there. It's really important that we continue to foster that relationship, which Carol and Laura and I have had lots of discussion about. Want to get back there to helping those people who can't. Those people who can, then donate so that other people can partner with you, because it's the power of people and committees and commitment and working together that's so important. I would say we need to decrease, one of the things I hear from the clinical team the most is we need to decrease the barriers to access. And if funding's a barrier to access or transportation's a barrier to access, that's my job. That's what we need to do to help to get people there. The fact that this started as research that gave us data that proves exactly what Dr. O has said is very powerful. It started at this organization and we've moved it forward. Our patients are benefiting from it, but we have work to do. 2,500 people have graduated or are a part of this program. We have almost 5,000 newly diagnosed cancer patients in the Waterloo-Wellington region on an annual basis. It's a sad statistic. We have more people to be involved in it, more people that we can help if we commit to working together. So I would say that individual clinicians' reasons are very patient-centric. Feel better, decrease your symptoms, get some fresh air, take a little bit of control of one component of your life because so much other control has been taken away. But the organizational commitment is probably from an administrative perspective, which is the hat I currently wear, needs to be the driving force to get these services into our patient hands. Thank you.
And Lori, I know you can add both your professional perspective as well as the intersection with your personal perspective as a daughter
Absolutely.
of a participant.
Thank you. And thank you, Laura and Carol, for the invitation to come and be with all of you today. My name is Lori, and gosh, when I first started working with the Regional Cancer Program back in 2006, on my 3rd day on the job, my mom was there at Grand River Hospital having her breast cancer surgery. So, I wondered what brought me to my role and working in cancer care, and then here my mom is diagnosed and needing help, feeling uber lost, and I found it very serendipitous over time. When I thought back to those early days. She was able to help me tremendously through her experience, her personal experience, and I hope that I was able to help her a little bit, guide her as I was learning all about the world of cancer care and moving forward. So Mom is with me tonight, and I thought I would just take a couple minutes to share her experience. Probably not too different from Beth and Anita's. I echo a lot of your comments and sentiments. I was smiling as I was reflecting on my mom and so many of the stories that we spoke every day, and she would share so many great stories about her experience with WellFit. you know, and for her, like it wasn't just about the exercise. It was so much more. You know, it was more holistic and integrated when I think about it, for my mom, and probably for all other WellFit attendees. You know, and this goes back to when she first started getting her radiation treatment, was when then it was suggested to her, probably on a little prescription paper, to come and join WellFit. So my mom was the perfect patient. She did everything she was asked and told to do. So she joined WellFit and never looked back. She was so excited. And so, you know, when I think back to the holistic piece, yes, there were tremendous physical benefits that I could see that she reaped. And thanks to the program. There were amazing instructors. Thank you, Lori Kramer, so much. I know she spoke about you so often with all the great work that you did with and for her. And she loved, with WellFit, the opportunity to work one-on-one with supervised instruction. You know, making those little corrections right there on the spot. And I said, Mom, you've got it better than me going to Good Life when I went. So, sorry, Dr. O. Still a goal. Anyway, yeah, over the course of her 11 years being with WellFit. You know, I used to marvel when over time she'd say, yeah, wow, like Lori's working me really hard today. I'm really feeling it. And every once in a while, and she had a great sense of humor, and she'd put her arms up, and I'd say, Mom, you have more muscular guns than me. And I could really see the visible improvement in her body and in strength. She really was in her best shape during her WellFit years. As well, and as the other ladies had indicated, that this provided for her an incredible social outlet. You know, she was a socialite. She was very active, and she thrived on that. And I know that was one of the driving forces that got her in every day as well, was not just the exercise, but the social component. She made deep connections and developed close relationships and friendships with other participants, including the instructors, and there were definite bonds there. Some of her closest friendships were made from WellFit, and you know, when I think back, she loved to attend. WellFit was so much more. It was the WellFit family, as was mentioned. The participants, they would get together and they would organize these WellFit potlucks that I remember Mom talked about so much and loved to take part in, and the monthly WellFit dinners, which then I started to get invites for. So I somehow kept dovetailing, you know, with the work that I was doing and being part of this group, which I so appreciated. And then as well, the mental health piece. This opportunity impacted her profoundly, and it gave her a positive outlook. It increased her self-confidence, I could see, as you know, every day went by, and she became stronger and stronger, really on all four quadrants: physically, emotionally, mentally, and spiritually. And I saw such tremendous growth in my mom that I was really proud of. And overall, her quality of life did improve. You know, I really could see the effect because I lived it with my mom side by side. And I too want to express my gratitude to the UW WellFit program for making the program so accessible to my mom and for other patients with cancer, as she really was able to live her best life. So thank you.
Thank you all for sharing, you know, the experienced or the seen impact of the program. I think it really emphasizes, as one of you, at least one of you said, like the holistic, the broad benefits of exercise as medicine. It's not just it's not just the physical, whether it's the health condition or physical function, it really is the broader impacts on your mental well-being, your social well-being, as well as that physical health. Now we've all, I think the first four have argued for why exercise should be a core component of healthcare, but we know that's not currently the case. As Paul highlighted this morning, even in cardiac rehabilitation, arguably the most established model of exercise within the healthcare system, only 30% of patients actually get access to cardiac rehab. So I'm going to ask Paul and then Carol and Matt for maybe some very beginnings of solutions with our time before we open it up, as I said, to audience questions. So Paul, to you, we see exercise as clearly integrated into the management of cardiac care, at least. Even then, as you said, 30%. Do you see, and if so, how do you see exercise taking a more prominent role in the management of other chronic conditions in the future?
So yes, this needs to be. This is going to be our collective mission in the room. This needs to be expanded as a core offering of all kind of care that we deliver. That the surgery, the procedure, the device, the treatment is not complete until the recovery plan is also established as part of that pathway. Giving the chemotherapy needs the time at the gym as well for the recovery from the chemotherapy or the heart disease that ensues. How are we going to get there? That's going to be a longer discussion, Laura, but let me just provide the opening bid that that's where we need to get to, that there is enough evidence to say this is beneficial across a wide spectrum of conditions. Whatever we offer up in acute medical care can be improved vastly by the follow-through with the work that these excellent people do. Thanks, Laura.
Thank you, Paul. Carol, you have been providing clinical care through exercise for, well, we can say 20 years in WellFit, but beyond that, really. And it still, remains kind of a standalone special model in many cases. Certainly at our center, there are these pockets, but it's not yet integrated. So to you, what do you think is really limiting the implementation of exercise as healthcare more broadly in an integrated way?
So I think saying more broadly, I got to admit that we have a great group here, and the reasons for success of the program are qualified exercise professionals with us today. And I think that's what we don't have enough in the broader communities or available in the healthcare and even exercise facilities. So I think that we need, and it's Paul alluded to, we need qualified exercise professionals, so our registered kinesiologist and our certified exercise professionals to oversee, implement, train, modify, and make an environment that's safe and effective for our participants. So I think that right now is a limitation. I also think within our urban areas, they're more concentrated, so we've left our rural areas or those who can't make it to the center are limited. So transportation and the non-availability of other programs. So I think we are moving in that direction, with the remote programming, but I think we need to make it more widespread. Another one is to get the physicians on board, Paul, that will have, and for us, we're working on a quick and easy referral system so that it's not onerous to the physician to refer not only to our current programs, but as we'd like to expand to other clinical programs, so our general physicians will be able to refer quite easily. So that doesn't become a barrier. So I think, in saving the last one, financially, that's a barrier. Okay? So we need, the cost of these programs are large because we are dealing with our facilities, the equipment, repair, and our qualified exercise professionals. So to provide it to everybody, we are not able to, we're missing people because of the costs involved in it. So somehow, if this can be integrated into healthcare so that it is actually providing some of these prevention, primary, secondary prevention, at a cost that's achievable to everybody and not limited to those that can afford it.
Thank you. That's a huge barrier, as we see. If people have to self-fund exercise, it's going to remain restricted. But that first point that you had around, having sufficiently trained staff, I think it's a challenge. But it's interesting because we have been graduating kinesiologists and exercise professionals for years. But what's been challenging is we lose them because there's not an obvious place for them within this healthcare system. And I think, really kinesiologists, as well as clinical exercise physiologists, would be central in this role of exercise as healthcare. So our last question from me before we open it to the audience will be to Matt. From your kinesiologist role and your board member of OCA, kinesiologists are really poised to take a central role in exercise as healthcare. For you, what are the critical steps needed to integrate kinesiologist services within both family health teams and more broadly within the healthcare system?
Yeah, thank you, first and foremost, for having me today. And I'm really happy to speak after some of you because I hope I can address and speak to some of the barriers that we talked about. A little bit about myself. I started as a student intern at the Guelph Family Health Team a number of years back and had the privilege to work with, at the time, the president of the OKA. And we were one of very few KINs working directly in primary health care. So my role at the Guelph Family Health Team as a KIN focused around chronic disease management, mainly in their diabetes program, cardiovascular program, and then moved on into chronic pain. With the kinesiology becoming a regulated healthcare professional in 2013, that allowed us to become registered and insured healthcare clinicians, which really paved the way for us to start our roles in primary care. That has been a slow progression for a number of reasons, barriers, things like funding and things like that. But I think, as part of the OKA, I've been advocating for the increased usage of KINs in primary healthcare and in chronic disease management. In doing that, I've kind of looked at 3 different things and 3 critical steps that we really need to address in order to continue that progression. First and foremost, it's education and awareness across the healthcare industry in general. Currently, there's about 3,000 practicing registered kinesiologists in Ontario. We have 184 family health teams across the province, and we have 40 registered kinesiologists working in primary health care. So there are not many of us. That means that not many people have the access to the profession, to the knowledge, and to them as part of larger interdisciplinary healthcare teams. Because I'd like to think we make a huge impact on the teams that we're in, and we're not seeing that across because we're not in those teams yet. I have worked with the University of Waterloo, Guelph Humber, the University of Guelph, University of Toronto, and some of the professors, and they did a cross-sectional online survey of healthcare professionals and some of the barriers that they have. And physicians and nurses scored the highest in lack of awareness of the scope of practice of kinesiologists as being one of the highest barriers to referrals. So I think getting out there and demonstrating what exactly we can do in chronic disease management is a big thing to helping integrate us into that. Second to that comes the actual integration and the utilization of that, of the profession in the family health teams and in primary care. Each population has a little bit, or each organization has a different patient population that they might be working at or with or targeting. And it's about looking at how they can tailor the kinesiology discipline to address those. Is it chronic disease management? Do we need diabetes education, pulmonary program, cardiac rehab? Or is it more MSK related? Do we need low back pain help and low back pain programs? So we can look, and those organizations can tailor the use of kinesiology to help with that. The other part is the implementation piece and the use of ministry-funded resources. In 2018 to 2021, the Ministry of Health Recruitment and Retention Initiative allocated ideal salaries and funding for the use of kinesiologies and standardized that across all of the other healthcare professionals. And I believe their salary complemented with the large scope that they can do really makes a great business case for integrating a kinesiologist into the program. And we talk about patient focus quite a lot, and when we say that, we often think of the one-on-one patient interaction, but a kinesiologist can also be used in quite a lot of group education, as we're seeing, as well as community outreach. We use kinesiologists to do community outreach, community walking groups, as well as we run a citywide health initiative with the City of Guelph. We also then turn and use our kinesiologists internally to run our ergonomics and our MSD awareness programs for our own staff health. So there's a large amount of usages of the kinesiology profession, and I think it makes a great business case to help address the needs of the community, the patient individually, and the organizations. Lastly is standardization, support, and development. And this is for kinesiologists as a whole. With only 40 working in primary healthcare, we have a ton of information on how exercise directly impacts health, and we know that. We don't have a whole lot of discipline-specific outcomes because the kinesiology profession is relatively young and they're relatively underutilized. So a big thing for us, and it's kind of, chicken before the egg kind of ordeal, is we need to start cementing those kin discipline-specific outcomes so that we can drive that case and increase access and increase utilization and increase the buy-in that we need from the organization to say, hey, we need to bring a kin on board. We can do X, Y, and Z with this. So I think, again, those three big steps are education and awareness across the industry, integration and utilization, and then standardization, support, and development of the kin profession.
Excellent. Thank you so much, Matt. I think there's a lot of really important points there for kind of the data we needed to move through for different models of care, that it really is. It's not just the randomized controlled trials that give us good evidence that we should be supporting exercise, but how do we deliver it, including the role of kinesiologists. I'd like a few things that you mentioned there too, like the outreach and the community facing, that it really is kind of the healthcare right through the community, that I think it'll be a connection in moving it forward. But I'd like to open now to questions from the audience. I know there's at least one online that maybe I'll start with. For those in the audience, you can either come down to the mic, but we also have a few runners who can bring the mic to you. So just put your hand up if you're interested in asking any one of our panelists a question here. So this question, I think, is directed towards Dr. Paul O, and especially your relationship with GoodLife.
Okay.
But the question is, are there any exercise programs that you know of in the community for cancer patients? And this is where they give GoodLife as an example. We offer one program, but for some, the university is, of course, a very intimidating space. So that maybe we can start with you, but Carol could also add in, or anyone else who knows of community programs.
Absolutely, and that would have been my answer as well. Let's ask Carol. I heard that's the right answer. That's the right answer.
That's the right answer.
But certainly in the GTA area, Wellspring is another kind of organization where there are the community-based programs that are available that are outside the hospital. Often they're close to cancer centers. Other cancer centers themselves may offer versions of cancer rehab exercise programming, but it may be more kind of tailored to their local clientele. An example would be programs at Princess Margaret or at Scarborough, or new ones that are developing in my hometown of Newmarket at the South Lake Regional Cancer Center. So I think folks are following Carol's lead in developing programs that are attached to cancer centers. Carol?
Yeah, I would say our partner of Wellsprings is Hope Springs here, and they do offer programs for a variety of reasons, and one of them was a walking program, so there's a few of those. There are the ones in the Wise that are supportive of it. I'm not positive there is any in our area right now, but I know Hamilton for sure. And also there's smaller physiotherapy groups that are offering exercise for people with cancer, but more on a one-to-one basis. Yeah.
Excellent. Thank you very much. Yeah, go ahead.
Thank you. A great presentation this evening. Great to be back as an alumni and join with you today. You've got a great model here with what you've built, and this is rooted in decades of experience. And recently, prior to COVID, Ontario was moving more towards the Ontario Health Team approach, linking acute care and community with primary care. And at the same time, we were starting to see funding models, including bundled funding for orthopedics, to ensure that those patients that were undergoing joint replacement would get the rehab care that they needed. And I know, Dr. O, you and I sat on the panel together to discuss and talk about bundled funding for cardiac rehab and perhaps other chronic conditions that don't get the same type of rehab services. And I can't help but think about some of the non-elective chronic conditions like COPD and CHF that continually go over budget on certainly all the local hospitals that I have been a part of in recent years. What is it going to take for the Ontario Health Team model to perhaps embrace the bundled funding opportunity for some of these additional chronic conditions to ensure that all those patients get the rehab care that they really need?
Maybe I can go first to Dr. O, and then Matt, if you want to add anything from the health team perspective, but go ahead.
Yeah. Zach, good to see you. Thanks for the question and the kind of the thoughtful analysis of where the system's at. And agree with you completely. It seemed like at a point that we were headed in the right direction, where this notion that we should provide funding that's attached to a person as opposed to a bed or a procedure or a device. A bed, a procedure, a device is not a person. It's not the care that she or he deserves. One hopes that when we look at thoughtful metrics like, are you functioning at home? Are you feeling as well as you can be? Are you doing everything that you need? Are you living or dying? That the funding would actually follow to achieve those outcomes, as opposed to, are you out of the bed? Are you out of the hospital in a short period of time? And are you not coming back? So I think we had the wrong metrics that we've been using for a long period of time when we focus on a device, a procedure, a disease. What will it take to get there? Absolutely. COVID's derailed everything, I think, for the last couple of years. We're very much looking forward to how in cardiac care that the episode might be changed to, if you need a bypass operation, let's start the clock at the time of your first meeting with a team, a heart team, a surgical team. But then let's make sure that we follow this through for 90 days, 6 months, a year, and provide all of the elements under one single umbrella to bring you the care that you need. There are organizations, health teams, that have moved in this way already, despite kind of going quiet on the bundles. So we're hearing terms like integrated care pathways, where we can actually put in all the pieces that people need. We need to do more work in this way. And I think if we all stand up and speak to say, these are the things that really matter to me in terms of my outcomes. We heard this in spades today, of the fabulous outcomes that can be achieved through long-term pathways, not long-term care, but care in the best way possible. So let's continue to have those conversations thoughtfully.
To try and speak to that a little bit from a primary healthcare lens, the Guelph Family Health Team utilizes what's called the medical home model of care. So we've been working to try and bundle and wrap that patient around their family physician interaction, and then with that, all of the subsidiary services, so their dietitian, their mental health, their kinesiologist, and the like. Lately, with the Ontario Health Teams, we're looking at integrating an integrated primary care team or an integrated primary care practitioner to help bridge that gap of coordination for all of those services. So again, it's relatively new, but that is the direction we are trying to move in. We're actually piloting some of that throughout the city to see if we can integrate that primary care team member into the office and see the outcomes that come from that.
Maybe I'll ask a question, and if there's anyone else who has one last one before we go to the reception in person and thank our speakers. How do we, I think one of the challenges in exercise in medicine is people see it as this easy thing that should just happen in the community, that people can just go for a walk or they can just go to their community center. How do we clearly make a distinctive argument, like distinguish exercise and healthcare and argue for that support of what some people see as, it should just happen by walking out your door? I'm not sure who I'm directing this at, but I'll maybe we'll start with Paul, but I'd love to hear anyone comment.
Thanks, Laura. Question mark? So how do we move the needle on this? And I think we've been facing this in our conversations as well. When I talk with learned colleagues that do fancy procedures, put in devices, the prevailing view, maybe it stems from the notion that people shouldn't move. There's that first hurdle to get over, that we still haven't changed 1950s or 1960s thinking. So exercise is indeed good, but it's sometimes views of programs is that they're cute. They're cute. The people just go around, walk on a track, and maybe lift a dumbbell. But I think in the right audiences, we might propose different messaging. And in clinical kind of quality places that we would say, let's stack up the evidence for this versus that to the use cases that I think for kinesiology of outcomes. I think we got lots of data. And again, some of the information we showed today, and we can find more of it across all of these conditions. Cancer would be another great example to say this is as important as that you were offering. It's become the norm. And I'm not beating up on cancer care, but just the norm now. New, exciting, targeted therapies, fantastic. We can treat conditions that we haven't been able to treat before. The opening bid on drugs is becoming $100,000 a year or more. All we're asking for is 1% of that to go to the 6 months of care that will help people get back on their feet, to recover from those exciting, targeted therapies. And together we can show that the outcomes are so much better when you do both rather than one or the other. It's not just something that one does on their own, that recovery exercise as part of that is actually a mandatory part of the pathway. Some places we've accepted this, like if you break your hip and get a new ball and pin put in, rehab is accepted. Well, you probably need that as part of your recovery. When the conditions are a little bit more, I guess, visible, apparent, cancer inside, heart attack inside, even sometimes stroke, that we argue that, well, people can do that on their own. Well, availing ourselves of the amazing professionals around us to help us in recovery can do so much more, take us to levels that we can't get to on our own. So these are the messages that we need to get out there. Our role in academia and this university is to continue to develop those evidence in that model. Our role together as professionals is to promote that in any way that we can. And our role as members of society is to keep telling those wonderful stories so that people will listen and say, this really needs to be out there. I'm being very political tonight, aren't I? It's very
Perfect.
interesting. Very well done.
So
Okay,
Paul,
thanks.
would you say that, you just talked about a $100,000 bill for pharmaceuticals. Why couldn't they support the side effects of their drug in terms of exercise? Is that a model that we could look at?
It's a wonderful idea, and sometimes it's interesting. So I think, Carol, you're saying let's think creatively about this. If you're tired, is there a mark in the middle of your forehead from beating your head against the door or the wall? That maybe we should think creatively, and perhaps there is appetite. We need a number of different parties at the table, and if it's a device or a pharma company that would say, you know, we would like access to therapies, we want access to patients, we want our products or drugs sold, and we will fund these things. We need these kind of collaborative partnerships, but we have to be okay with that as well, as kind of members of the healthcare system, that's a very different thing than we're used to doing.
And I just think, Donna, maybe you can address this. When we had a group of women on aromatase inhibitors, all the side effects are counteracted by exercise. So for those drugs that they need to take, it would be, you know, intuitive that they should support the use of those drugs.
I think that lots of the side effects are inhibited by exercise. I think approaching pharma companies to fund this type of activity is really important. And then we need Matt's help to say, what are we measuring? Because that comes back to how do we know it's helping? And then it turns into data and evidence that our clinicians can use to continue to support it, and we start things rolling. I mean, if we hadn't had the discussions 20 years ago, Carol, we wouldn't have the program running and working as collaborative partners as we have been for 20 years. So it's time to think, you're only as successful as you are creative. So let's think outside the box about how we can get this into more people's hands and do the good work that the patients tell us we're doing. That's overwhelmingly positive. It's a little intimidating to follow the two down at the end of the table because it is so amazing. How do we fund it? How do we get there? How do we measure it so that we can continue to spread it? I think those are our questions that we need to think about as we move through the evening.
Excellent. I'd like to ask one final question because I want to finish with, again, those most important voices on this idea of exercise as healthcare just versus, and I believe wholeheartedly it needs to be integrated in the community as well, but I'm thinking, you know, and we've talked a little bit about this, Beth and Anita, you know, you could have, in a model, like in many of the cases, I think many physicians talk about exercise, they say, well, make sure you exercise at home. Go for a walk. Can you tell me kind of, imagine if you can, you know, what would it have happened if you were told, go for a walk, exercise as part of, and that's it, versus the referral you got to exercise at WellFit. And we're not part of the healthcare system, but I'd say to WellFit as exercise as healthcare. What is the difference in that really being a structured part of the healthcare system versus a general recommendation?
Well, I don't know how Anita feels, but for me, I probably would have gone home and sat on my couch and felt sorry for myself that I was sore and tired and nauseated, and was there something somebody could give me to make me feel better? Mm-hmm. There's no comparison. I don't think there's any comparison to that and what we've received through WellFit, the actual exercise component part of it. What
Yeah,
would you say?
I mean, I would have walked. I always walked, right? But the medication I was first on, every joint in my body ached. Literally, every joint in my body ached. And I was taking it to stop the cancer. Didn't work after 4.5 years, but that's beside the point. I took it because the doctor said, take it. When I went to WellFit and worked with the professionals over there, they helped me deal with that. They helped me deal with the pain. They helped me deal with how I needed to maybe do this instead of that. So that wouldn't have happened with me just walking. And certainly years ago, old enough to remember this, the doctor would say, here, take these exercise home and do them. And I think if they got home, it would be a miracle. Because I was never in the athletic field at school. So walking was fine, but I never did any of those other things. So giving me exercises to do on a piece of paper means absolutely nothing to me. But going to a professional and say, you know, I just had this surgery, I ache here, what should I do? And they can help you because they're professionals. They understand body mechanics that I don't. So that's why you need that, and why you also need it for people who can't get to the center. There's a lot of people who need this same kind of help, who could live much happier lives if they could get the professional help. And I just like to say one thing, during COVID, everything shut down, except for this program. We were in our own homes, on our computers, getting support, yes, through a DVD or video kind of thing, but also we had times when it was a professional looking at us through Zoom and saying, no, Anita, you're not doing that one quite right, or you're doing that one too strongly. They were monitoring what we were doing. That would not have happened if we hadn't, or if I hadn't been given that prescription that this is actual medicine that will make me better.
Amazing.
And I don't think really at that time, people really knew that exercise was, I mean, sure it's good for you, but I don't think they really knew how good
It
was.
really is.
Yeah, the power. I think your words are so important for that. I do see one person. I'm terrible at cutting things off, so I'll give you a quick chance to ask the question and then thank our speakers.
I appreciate that. I wanted to thank you guys for the presentation you all put together today. I wanted to thank you, Beth and Anita, for the sharing your battles against cancer. It's a very strong story to hear. I guess my question would be directed at the Fantastic Four here, Carol, Matthew, Lori, and Donna. I wanted to ask how your respective organizations were utilizing the wealth of skilled undergraduates we have at University of Waterloo, and how we can, as students, expect to get more involved in this idea of exercise as healthcare.
I can tackle that one first. We take student interns. We did have a pause over COVID when we were doing a lot of remote work, but we do take students in. Being part of the family health team, you have access to a wide range of primary health care programs, so we try and expose students to different aspects. We have quite a robust kinesiology program in our diabetes, our chronic pain usage, so that's one of the best ways is reach out to us. And we can, if we don't have space with us, we have connections with other family health teams and kin programs that we can direct you to. Excellent. As well as the OKA. Thank you. Also sitting on the board of the OKA and having Ontario Kinesiology Associations, you can reach out directly to the OKA and look for student intern opportunities as well. And funding.
You know, in a hospital that's publicly funded, we can't repeat what's happening here. We can't. And so my vision for the program that I'm in across the region is to support this program. And if that means that we have more patients coming, then that should mean that we have more kinesiologists working. And you know, we're asked to do it for occupational therapy and for lymphedema and for dietitians and for social work, right? So you can see our patients need a vast variety of support, but I could never build what's been built here. And so my thought is that we need to partner so that we leverage the expertise that there is. And if we have it in Kitchener, and say we built it at the Cancer Centre in Kitchener, then what about the patients in Cambridge? And what about the patients who are in Guelph? Because I want them to use the expertise in Matt's clinic. The family health team in Guelph is a model for the province to follow. So I want to build that. But I think what we need to do is know what each other has and share that so that we can refer back. So when I sit at the OH West table and say, what is it that we want to focus on, right? Increasing exercise is a big piece of it, but knowing that services at the Guelph team means that we can refer patients there to get it, or if it's oncology specific that's required, then they're referred to WellFit. So I would say we want to partner with the places who do it really well rather than replicating
and duplicating dollars, that we could actually expand the service here rather than trying to replicate what we have. So in the oncology program, I would say that would be the goal. At least, well, I'm the director there, just saying.
Nice.
Thank you so much for your question. I mean, I think our undergraduate and graduate students are the future of exercise as medicine. And if we can train you and get you the experiences in these places, in family health teams and beyond, that's how we're going to change something, right? We've got to move from having just 40 kinesiologists in family health teams to every family health team having a kinesiologist to support not only diabetes and chronic pain and
Pulmonary.
cardiac, but all our health conditions, right? So thank you for finishing on that note, and you will, I hope, be part of the solution. And so with that, I want to thank all of our panelists. I'll start with Paul for setting an inspiring view for why we all need to collaborate on creating change for the healthcare system with exercise as a key part. That's, we're starting to think about healthcare more holistically, but exercise in and of itself is holistic. So let's think about all those benefits. And then for the panelists, for sharing your diverse perspectives on the impact and how we create change. I hope that the conversations that we've had in this panel today, over the course of the day within the department, and hopefully in the reception with all of you, will really start to take more of those steps towards improving the health of all our community members through exercise as healthcare. And so I do have presents for you all, but I'll hand those out rather than going along. And for now, I just want to say my deepest thank you from myself, the department, from the audience for being part of tonight. And thank you to everyone in the audience for coming and taking the time to be here. I hope those of you in person are able to enjoy some of the food that we have available and take the time to chat about all our inspiring speakers and thoughts we've had today. So thank you.